Hi, everybody. My name is George Escaravage. I'm an oculoplastic surgeon in Wilmington, North Carolina, in private practice. And I was invited to share my experience with the EZYPOR orbital implants in the setting of enucleation. I will say that I was an invited speaker for FCI, but otherwise I have no other disclosures. Why are we here? Enucleation surgery is something that we do on a regular basis for our patients, and it's really an opportunity for us to impact their lives. We can cure disease, we can stop pain, and we can give them the ability to heal. It's a fairly standard thing that we've done, and it's honestly, implants have been used for since 1885, starting with the mule sphere. And we've continually involved the materials and the modifications of the implants to try to achieve and improve our results so that we ultimately achieve the ultimate ideal orbital implant, which I would argue doesn't exist yet. So the question is which implant would I use? And I'll just say that this is not the scope of this article, or excuse me, of this lecture to cover everything. It's just not impossible in this time that we have. But you can see there's lots of questions. So hands down, pegged implants give the best motility, but they're largely not used anymore because of their postoperative complications. Non-porous implants are the next thing to consider, and they should be part of any surgeon's armamentarium because they're cheap, they're easy to use, and they're generally pretty easily available. But they're saddled by the fact of implant migration, particularly supratemporally, and the difficulty in maintaining the implant if there's any evidence of exposure, as they'll pop right out, and I've had some come to me in a Ziploc bag with my patient coming into clinic. So the wrapped implant should answer this concern. It's a barrier, and the muscles can be sutured to it. The trouble is as you can see there, we've got added costs, whether they be time, material costs, and they do prevent the advantages of the fibrovascular ingrowth. Hence the evolution of the porous implants. They address these concerns in that they do allow fibrovascular ingrowth, which in literature has been shown to help with implant extrusion, less migration. However, the other proposed benefits of improved motility and lower infection rate haven't really panned out in the literature as much as initially proposed, which means that we don't have a go-to implant for every type of surgery. So this is the question that we're still trying to answer at this point. And I would argue that based on the surveys with EZYPORs as well as the preponderance of data and literature regarding porous implants, that many of us still reach for a porous implant as one of our first choices when in the OR. So I just want to share for a minute the evolution of my choice. And you can see here the influencing factors. I've been in a private practice in a small town in eastern North Carolina for actually 15 years, and I was the first orbital surgeon in the area. So a lot of my, it started with convincing the hospital that I needed implants to start with, and in the beginning I was only allowed one. So I had to choose carefully. My population had a lot of previous surgery, a lot of retinal implants, a lot of glaucoma implants, and as a result very scarred. And I also was, for the first time in my career, dealing with the fact that I had surgical assistants that didn't know what they were doing and didn't care. And I wasn't used to that coming out of fellowship. So I had to learn to become very independent and try to get the best results possible, which definitely wanted me to get the best implant I could, giving me the chance to get it right the first time, given that we've also had compliance issues with post-op follow-up. So the first ended up with the MedPor SST EZ implant. It affords the benefits of the fibrovascular ingrowth. You can actually suture to the actual implant, and it was the first with the suturing platform that was available to my knowledge. But what I found, despite my best efforts, no matter what needle I used, no matter what technique I used, I always found it difficult to navigate those suture tunnels. So the question would be, why don't you wrap it, or why don't you use a wrapped implant? And like we talked about before, there are some other issues with this, but I want to show you this beautiful video that is really about 3.5 minutes long. I'm going to compress to about 9 seconds. And you can see, it's beautiful. It looks great. This is a very practiced hand in a very ideal OR situation, what I would argue is not always the case in many of our ORs. So, how did I get to this? So about late 2022, I became aware of FCI's EZYPOR orbital implants. I was very intrigued by the fact that we're very familiar with porous polyethylene. There was no need to wrap, as you could suture directly to it. And the highly compressed suture platform on the anterior surface made it very easy to suture, as well as afforded a very similar surface to the non-porous implants, for which there seems to be less concern about an abrasive surface that could break down the anterior, the tenons in between there and the prosthetic. So very similar specifications, has a great porosity, which affords a great fibrovascular ingrowth. It's available in sizes from 12 to 22 millimeters in 2 millimeter increments. The suturing platform itself is very robust. It can withstand 4 newtons of force in suturing, as well as orbital manipulation once it's in the orbit. So I haven't had any problems with that. Like we talked about before, the smooth anterior surface affords a very smooth interface for the overlying tenons and eventually the overlying prosthetic as well. This is really the beauty of the implant in my mind. You can see the large suturing tunnels. There are 8 of them, 4 on each side and 4 anteriorly. There's sufficient space to pass needles of different sizes and curvatures, as well as the ability to reach a forcep in there if you really have a tough angle to get. Also helps in non-ideal situations, which we'll talk about a little bit before. And I just want to show you for a minute a quick video, if I can get this to pop up, of placement. Oh, let's see if I can go back for a second and get that to work. Maybe I need to be patient. Here we go. So you can see that actually grabbing the tip of the needle and passing it with the swage stand through first. But this is an example of the anterior placement. But I don't know about you guys, I always have a hard time seeing what I'm supposed to see in presenters' videos, so I took the liberty of making a couple diagrams, and please don't judge me based on my PowerPoint skills. So here's the equatorial insertion, where you can place the muscles up to the pillars of the implant. They can go around the pillars and then through the anterior windows. And here's with all 4 placed. Another option is anteriorly, and it can be placed either over or under the horizontal platform and exit through the anterior windows perpendicular to the muscle placement. I think it goes without saying that despite what implants you choose, there are a couple of principles that supersede the actual implant that you've chosen. The appropriate selection of the implant is very critical, including size. You need to make sure you adequately rehabilitate the orbit with the largest implant that the orbit can take, as long as there's no anterior pressure on the tissues and the implant stays seated when placed. Also critically important with placement, it needs to be behind a healthy amount of tenons. And if that includes way behind the posterior tenons as well, so be it. As many times, like we said, in my practice I encounter very scarred, very ineffective anterior tenons. Different authors argue over whether single or double layer closure is important, but the most important thing is that tenons is closed watertight overlying the implant. Just a couple of examples with conformer and with prosthetic of our EZYPOR patients. And then just a quick video here if I can get this to work as well. So as you can see, a little bit of a superior sulcus defect. Motility is good. I have no doubt that it'd probably be better with a peg, but this patient's happy, she's moving well, and I've rest easy that she's been doing well for a couple years now with the orbital implant intact. So I did a back of the napkin analysis of what we've done over the past 18 months in our practice. We've got 3 different surgeons, 2 different settings. You can see we tend to handle pretty sick eyes with our enucleation population. And EZYPOR is quickly making inroads as our preferred porous implant. In fact, I only use them when I'm choosing a porous implant for my surgery. So we've had 1 exposure, and if I can show you here, here's the real problem. But little anterior suture, anterior platform exposure, and the more I thought about it is it could absolutely have been poor surgical choice, and poor surgical technique. However, the more I thought about it, and I met her middle of the night with a large corneal perforation with extruding uvea and a blind eye, and knew she had had previous surgery, but she couldn't expound to what. Finally got the records later and found out she had 2 failed corneal transplants, and basically had a wicked case of mucus fishing syndrome. Every time she came in post-op, she would show me what she's picked out of her eye, and I would watch her sharp fingernails just dig in her eye constantly. So we're working on how to resolve this right now. So in summary, EZYPOR implants provide all the advantages that we've come to enjoy and we've come to read about in the porous implants. They allow fibrovascular ingrowth, you can directly suture to the implant, and you can manage exposures a lot easier than non-porous. However, it also has the added advantage of being fairly smooth on the surface. So I can't say it's non-porous, but it's pretty darn close. And that kind of addresses the concerns of porous implants traditionally in the literature as well. Like I said, the real selling point in my mind is the ability to sew the muscles to it easily. You know, efficiency in the OR is critical, and the ease of being able to do it without much manipulation is also very helpful as well. So enucleation is something that we can do on a regular basis that can really help cure patients and really can help them heal. The choice of implant is important, and there's, like I said before, there's no perfect implant for every surgery yet. I would argue that EZYPOR offers the has offered an advantage in this evolution of the porous implant, and is something you should consider to use. Thank you. Hi, my name is George Escaravage. I'm an oculoplastic surgeon in Wilmington, North Carolina. I would say they have a wide variety of products and are constantly innovating, which has definitely been helpful in supporting my practice. I think the first thing that pops out to me is the support I've received from the company itself. Whenever I've had a need for an implant, whenever I've had an idea for innovation, they've always been supremely responsive to any ideas that I've had and supportive of any needs I've had.